Evaluating the patient with chest pain is clearly part of core training in emergency medicine. This presentation is so common that there will hardly be a day that goes by that you won't see this as a chief complaint. Not only is it common, but chest pain also represents an area of high risk medico-legally and an area in medicine where a lot of healthcare dollars are spent, often unnecessarily. My name is Todd Grant. I was an emergency physician for 32 years, and I am currently a medical educator active in CALS and other programs. I would like to walk you through the diagnostic process of working up chest pain and how we determine an appropriate disposition for these patients. While there are many possible causes for chest pain, our first diagnostic responsibility in the emergency department is to identify or rule out the major, immediately life-threatening causes of chest pain. These would be acute coronary syndrome, including myocardial infarction, pulmonary embolism, and acute thoracic aortic dissection. We begin by taking a thorough history, although it is important to point out that in some cases this occurs simultaneously with or even after other important interventions, such as assessment of vital signs, placement of a cardiac monitor, or other measures as indications arise. Important elements of the history include timing and onset of pain, its character, sharp, dull, localized, pleuritic, or not, location and radiation, and associated symptoms such as nausea, vomiting, lightheadedness, syncope, and shortness of breath. Pertinent negatives, the absence of any of these symptoms, can be just as important to elicit and record as positives. Past medical history is often important as well. Obviously, a patient who has had a previous MI or DVT would be more likely to develop similar disease than would a patient without this history. Another important element of history in chest pain is the determination of risk factors. Risk factors for coronary artery disease differ somewhat from those for pulmonary embolus or aortic dissection, but until a definitive diagnosis is reached, it is important to assess risk factors for all three conditions. In addition to indications of general status, such as diaphoresis and signs of hypoxia or impaired perfusion, the physical exam should be careful and focused on clues to chronic and acute cardiovascular disease, including assessment of pulses and bruits, presence of heart murmurs, status of neck veins and other signs of heart failure, peripheral edema, and presence of lower extremity edema or tenderness. The examiner should also be alert to findings that would support an alternative diagnosis, such as the rash of herpes zoster or point tenderness over a rib. Failure to carefully search for clues on the physical exam can lead the provider down the wrong path. Because of the specificity of some ECG findings in diagnosis of ACS, and because of the ease and utility of performing a chest X-ray, there is a low threshold for performing these tests in most adults with chest pain. Additional testing should be done on a selective basis depending on our impression after this initial evaluation. Acute coronary syndrome is the most common concern among our big three causes of chest pain. The combination of substernal chest pain, pain radiating to neck, jaw, back, arms, or shoulders, nausea, vomiting, diaphoresis, and/or shortness of breath, and ECG findings indicative of STEMI or ischemia are classic, but any of these characteristics may be absent, and atypical presentations, such as epigastric pain or, in the elderly, confusion, may occur. Relief of pain with nitroglycerin is important to note, but is not definitive. In most adult patients, age alone is a sufficient reason to consider the possibility of ACS. Previous vascular disease, diabetes, smoking, hypertension, hyperlipidemia constitute additional risk factors. In all patients with presentation consistent with ACS and any of these risk factors, both an ECG and troponin should be done as part of the initial assessment. In most cases, basic treatment for suspected ACS should be instituted on admission to the ED. This includes aspirin in almost all cases, nitroglycerin for ischemic pain in the absence of contraindications, such as hypotension or use of erectile dysfunction medications, oxygen for hypoxia, and morphine for pain unresponsive to nitroglycerin. Interpretation of the ECG represents the next step in determining the likelihood of ACS, assigning the patient to a risk category, and mapping out a plan for further assessment or treatment. The most straightforward situation would be an obvious acute STEMI. As serious as this condition is, most hospitals have well worked out protocols for treatment and transfer. If the ECG does not show a STEMI, as in most situations it will not, then the next question is, are there changes strongly suggestive of ischemia, which could represent non-ST segment elevation MI or unstable angina? If the initial ECG is non-diagnostic and there is sufficient clinical reason to suspect ACS, additional ECGs may be performed at 15 to 30-minute intervals. A normal or nonspecific ECG does not rule out ACS, but may, along with other information, allow for placement into a lower risk category. Except for a clear-cut STEMI, in most cases troponin results are added to ECG findings in order to determine the course of further workup. Elevated initial troponins usually indicate myocardial infarction, and the patient should be managed accordingly, generally with a consultation from a cardiologist. A second troponin should be drawn, commonly at 3 hours after the first, in order to confirm a pattern of elevation consistent with MI, but consultation and treatment should not wait for this result. If initial troponin is normal, a risk score such as the heart score should be calculated and need for further workup determined on this basis. In these low and intermediate risk patients, there will be considerable variability in management based on hospital resources, patient characteristics and preferences, and consultant input. Options include continued ED observation with a 3-hour troponin, admission to a monitored hospital bed or observation bed with additional troponins and ECGs, non-invasive testing such as coronary CT angiogram, and/or expedited evaluation through stress testing and imaging. Patients with ongoing chest pain consistent with ischemia, or those with arrhythmias or heart failure, may be candidates for immediate invasive evaluation regardless of ECG and troponin results. In addition, symptomatic patients and those with a high or intermediate risk of ACS should be treated with antiplatelet agents, nitroglycerin, anticoagulants, and oxygen as indicated, while pursuing a more definitive diagnosis. On the other hand, for those patients with very low risk scores and normal ECG and normal troponins at 3 hours, discharge with planned follow-up may also be an option. Consultation with a cardiologist is highly recommended before reaching a final decision. The next diagnosis we want to consider in our approach to chest pain is pulmonary embolism. To be clear, presentation of PE is usually sufficiently different from ACS to allow the clinician to pursue one diagnosis or the other, but there are exceptions. For our discussion, we will assume that ACS is not clinically likely or that the appropriate diagnostic tests are being done simultaneously with assessment for PE. As in ACS and most emergency conditions, a careful history and physical exam are the most appropriate initial assessments. While we are discussing PE in this video on chest pain, in fact, dyspnea is the most common single symptom of PE. Chest pain, when it occurs, is classically pleuritic. On physical exam, tachycardia is the most common finding. Tachypnea and possibly mild hypoxia with normal lung sounds raise the suspicion for PE. However, PE is notorious for its subtle and variable presentation and nonspecific findings. For this reason, assessment of risk factors and the use of predictive tools is essential when this diagnosis is being considered. Risk assessment tools such as the Wells criteria can be used to determine initial risk level for PE. Those with a Wells score of 5 to 6 are in a moderate risk category, and D-dimer testing should be the first step, with CT angiography to follow if the D-dimer is elevated. For those with a Wells score of greater than 6, immediate CT angiography without D-dimer testing is indicated. For patients chosen for CT examination, anticoagulation while awaiting the scan and results may be reasonable if the patient is not at particular risk for bleeding complications. For patients who have a score of 0 to 4 on the Wells criteria, the pulmonary embolism rule-out criteria, or PERC, can be applied. Patients who fulfill all 8 PERT criteria probably require no further workup for PE. Patients with 1 or more PERT criteria positive should be considered for D-dimer testing. On occasion, PE presents as catastrophic shock, syncope, or hypoxia. In these cases, bedside cardiac evaluation with ultrasound, looking for evidence of a dilated right ventricle, may have to take the place of CT. And anticoagulation or even thrombolytic therapy may need to be instituted without definitive proof of PE. The final condition in our big 3 is thoracic aortic dissection. This is less common than the other 2, but just as deadly. The classic presentation is severe, tearing, unremitting chest pain radiating to the upper back, but less dramatic presentations can occur as well. Dissection is notorious for producing symptoms in multiple areas and organ systems. As the wall of the aorta splits, the openings of major vascular branches may be occluded, resulting in diminished pulse and/or blood pressure in upper or lower extremities. Occlusion of cerebral arterial trunks may result in a stroke-like syndrome, and compromise of spinal cord arterial supply may result in lower extremity neurological deficits. If the dissection proceeds backwards to the aortic root, acute aortic insufficiency with a diastolic murmur and heart failure may occur. Dissection of the coronary arteries may produce an MI. Dissection into the pericardium may result in tamponade. Aortic dissection should be suspected in the chest pain patient with any of these findings. Marfan syndrome, while uncommon, is associated with the condition. So look for the long, slender body habitus that characterizes this syndrome. While some abnormalities may be seen on chest X-ray, an acute aortic dissection is not an aneurysm, so a normal chest film does not rule it out. Chest CT angiography is the definitive imaging test. As in PE, make sure the CT tech and radiologist know what you're looking for in order to select the proper dose and timing of contrast. If the suspicion is high enough, treatment may begin pending CT. It consists of lowering the blood pressure to levels of 120/80 or below. Labetalol, given in intravenous bolus as needed, is the simplest way to achieve this. If the condition is confirmed or cannot be ruled out, the patient will require transfer to a referral center with critical care and thoracic surgery capabilities. We're almost done with our discussion of chest pain, but it would be incomplete without a reminder that the majority of patients presenting to the emergency department with chest pain do not have an immediately life-threatening condition. Of the 6 million ED visits for chest pain that occur annually in the U.S., only 8 to 15% represent life-threatening illness. Minor trauma, muscular strain, GERD, pleurisy, and other conditions commonly produce chest pain. While our most important job is to identify or rule out the lethal conditions, this process should be individualized and guided by a careful assessment of history, physical findings, and risk factors, rather than the application of a shotgun approach in every case.